show us even invasiveness, but they are not well equipped to show us treatment responses and things like that. And that's why we call them novel techniques. These are techniques that have been evolving over the time. They offer non-invasive ways of understand the tumor biology. We can understand the metabolism that's going on within the tumor and around the tumor. You can understand the microstructures, new angiogenesis that are going on around new blood formation, the metabolism, the changes, the chemical constituents. These are novel techniques that can help us now to give personalized treatment and targeted treatment that can enhance the diagnostic accuracy in these patients. And to be able to monitor, to look for things like tumor recurrence, for subtle changes in patients. These are what novel techniques are assisting us to do. And what are novel techniques? They include things like susceptibility-weighted imaging, dynamic contrast enhanced MRI, diffusion tensor imaging, perfusion MRI, MRI spectroscopy, chemical exchange saturation transfer imaging, functional MRI, and radionomics or radiomics and machine learning tools, which are computational imaging techniques that help us to further characterize tumors and do prediction analysis. Now, what is susceptibility-weighted imaging? I'm going to give you just a very broad overview. So the image you are seeing here is a susceptibility-weighted imaging. It enhances the visualization of not just the brain, but if there are any microhemorrhages, which sometimes can be a constituent of tumors, and it helps us to demonstrate even the characteristic patterns, the characteristic pattern of vascular nature around the tumors. It has a very high sensitivity for blood products and is very good for characterizing tumors. It can improve the detection of not just microhemorrhages, but also provide valuable information about the tumor aggressiveness and how these tumors, when they are treated either by radiation or surgery, how they respond to drugs and things like that, and if there's any recurrence. Also, susceptibility-weighted imaging helps us in the visualization of venous structures. It can demonstrate, like I said, iron deposition, which can be seen in tumors in terms of like calcific changes and things like that. These are the things to be able to differentiate calcific changes from hemorrhage, things like that. So it's one of the new techniques that is used. And this is just a case to just demonstrate to you of a case of a case that is actually a unique meningioma that looked like on CT like an intracerebral hemorrhage. But with diffusion, with susceptibility-weighted imaging, if you look closely at the image on the right, you could see that this is not just the FLAIR image, of course, demonstrates the area of blooming and perilesional edema and things like that. But the susceptibility-weighted images, you could see there are some microstructures, new vessels, even within that lesion, which suggests that this is not just a hematoma that appeared on CT. So these are the kind of things that novel or advanced techniques help us in demonstrating or characterizing tumors. Another technique that is important for demonstrating lesions is diffusion tensor imaging. It's a non-invasive technique. It doesn't use contrast and doesn't require any radiation exposure. It measures the movement of water molecules in the tissues. And by this, it creates a roadmap for the brain wiring. It demonstrates the axons. And it helps us to measure the movement of water molecules along white matter tracts. The healthy fibers in diffusion tensor imaging usually will show restrictions, and then they will show clearly. But when there's a damage or disruption to the fibers, the water is allowed to move more freely, and this can be demonstrated using color coding and things like that. And these techniques helps us in visualizing the relationship between tumors. And of course, tumors will disrupt these white matter fibers, and surgeons can use this for surgical planning, how to be able to do what you call nerve sparing surgeries and things like that. That's one of the unique things about diffusion tensor imaging. It demonstrates tumors uniquely, and for surgical planning, people can navigate around these critical areas to avoid damaging critical areas or nerve fibers. It also, of course, in terms of follow-up of cases, you can also assess white matter integrity, and it also provides, it provides you with the patterns to actually look at white matter integrity and give you some additional information as well about the diffusibility or integrity of the white matter fibers. Another unique or novel technique is what is called chemical exchange saturation transfer imaging. And this is a unique technique that measures the chemical properties within tissues or within lessons. And what it does is a unique technique. It's like you shine a light, through using some certain sequences to identify certain molecules. And these molecules, once they pick up this signal, they're able to transfer their energy or to other surrounding tissues. It's like when you give somebody a hot potato and the person holds it and it feels hot and quickly throws it to you. Now, once that movement, that transfer, it's what the computer measures, or the MRI signal is measured. And by measuring these things, you are able to determine the chemical structures or the chemical compositions of tumors. And this is what is called chemical exchange saturation imaging. It helps us to understand the metabolic characterizations of tumors. And the information it provides, it helps us to understand tumor metabolism, and then can differentiate one tumor from the other, and then help us also subclassify tumors. It's very good for what we call biomarker identification. And it's usually associated with understanding the tumor progression, the invasiveness of tumors, and how we can personalize or further personalize treatment in patients. So this is just an image to show you the nature of a chemical transfer saturation transfer imaging looks like. You see the conventional post-contrast T1 weighted image on the left, and you can also see the flare image in the middle. But with this one, you have this weighted molecular imaging based on certain characteristics, in this case, glutamine. You can also see that apart from just looking at the tumor, you can also see the extent or the invasiveness of the tumor demonstrated in this image by the arrows. You can see something that were not clearly demonstrated with the conventional imaging. This is another image that shows you the role, of advanced techniques. You see the flare, the comma, the first row of image on the left shows you the conventional pattern of the tumors on the flare image. Then you have, of course, the CEST imaging, and then combining this with other PET imaging. You can see that tumor more better demonstrated, and we're able to demonstrate using spectroscopy, which I will discuss soon, able to help characterize the metabolic constituents of the tumor. And the variation of these metabolic constituents help us to further characterize the tumor and subclassify them. MRI spectroscopy is that one that talks about the metabolites that are contained within the tumor. And these metabolites are several. The details, of course, which I will not bother to go into, but understanding the metabolites within the tumor, the variation, the changes in the metabolites helps us to further demonstrate the types of tumor that we have. MRI spectroscopy works in a very simple way. It's just like you send a signal, and certain metabolites respond to that signal, and they kind of vibrate. And once they vibrate at a particular frequency, the computer picks it up and tags it. And you can look at it on a spectral pattern and demonstrate the various chemical constituents in a particular tumor. Now, it is non-invasive, and it assesses metabolites within a particular tissue. And there are different metabolites that can be assessed: the N-acetyl aspartate, choline, creatinine, and these are the things. And all these metabolites are actually looked at. They have, each of them respond at a particular spectra, at a particular level, depending on the product. So knowing the line, you can be able to ascertain which tissue or which metabolite you are dealing with. And each of them have there's a normal spectrum. There's a normal spectrum that is expected. When that normal spectrum is distorted, the distortion, it is what is used to characterize the tumor. There are two methods in MRI spectroscopy. You have the single voxel, where you take a particular tissue or a particular area, and you measure the metabolites in that area. And then the multi-voxel is that you take an area and put multiple points to see the distribution of the various points in that tissue. By looking at that, we're able to demonstrate and give like a spectral pattern to show the various metabolites in a particular tumor. And its clinical applications are very, very, should I say, very, very diverse in the sense that you can use this to sub-classify tumors and also to monitor tumors and then to determine if there's any, whether tumors are neoplastic or non-neoplastic, and if there's any recurrence after maybe treatment or after surgery and things like that. So it distinguishes neoplastic from non-neoplastic tissues, has a very high accuracy, and also it helps us to not, like I said, to look for recurrent tumors and things like that. And also, of course, to help us to differentiate various tumors. This is a case of an oligodendroglioma, which, of course, the spectral pattern here is distorted. If you look at the choline and the N-aspartate patterns are all distorted. This distortion are what helps in subclassifying tumors using these advanced techniques. Another technique that is an advanced technique that is also used with MRI is called the functional MRI, where you use the oxygenation, the level of oxygenation within blood by the MRI using to be able to detect the changes in oxygen in the blood can show that the certain signals when you perform a particular task, you need more oxygen to perform a particular task in the brain. And so we can use these functional techniques to determine areas of the brain that are functional or not functional. And functional MRI helps in this, for surgical planning. Before you even go into surgery, you want to see, are there areas of the brain that are still active or non-active? And this helps to guide surgeons. So this is what a functional MRI looks like. When you put the patient inside the MRI and you ask him to think about something or to do something or to say something, there are functional areas of the brain. There are functional areas that are responsible for speech, for vision and things like that. So when you're looking at a particular thing, certain areas of the brain that are required to actually transmit that information, they light up because they require more oxygen. Oxygen flows into that area. And when oxygen flows into that area, the computer is able to send show that there's a signal in that area. So you can say when somebody is lifting his hand or lifting his leg, you can say, oh, this is the part of the brain that is functioning. So this gives you a pattern of the brain in a particular tumor to see the two areas of the brain and how the function of the brain can be affected by tumors. If you look at this image, you will see that there are two side by side and asking a person to perform a particular task. And you can see one area is what is being moved or affected more by the tumor, which is on this case, which is on the right-hand side. So functional MRI can, using these color-coded techniques, show us if the tumor will affect the functionality or other the speech, other the movement of a particular place, and how you can be able to do what you call sparing, to be able to prevent damage or to be able to retain certain functions in a person that has a tumor you want to go and do surgery for. So these are tumors and how they affect certain functions. The lighted areas are areas where a patient is given a task. See the relation of that task being affected by a tumor. So just want us to look at cases. I know I've run through several cases because I don't want to take too much of our time, but these are just some cases to show you how advanced techniques can be used to help us in demonstrating or characterizing tumor. Here is an 11-year-old patient with biopsy-proven thalamic high-grade glioma, and of course has an EGFR8 mutation. Now, if you look closely, you'll see the conventional techniques, the T2 or the T1, and then the FLAIR imaging. And below, you will see this is called the tractography, the one that shows more of the white matter tracts, which is basically color-coded for the efficient tensor imaging. Apart from that, you also have the perfusion MRI perfusion that looks at the blood flow within the tumor. So the blood flow within the tumor helps us to also further characterize how is this tumor. Is it very vascular? Is the vascularity increasing? Is the vascularity decreasing? These are techniques that can be used in further monitoring patients. Here is another case. This is also another showing you a multi-parametric use of MRI techniques to demonstrate, apart from just looking at the T1 and T2 weighted images of techniques, you're able to look at the metabolites. You can look at the perfusion, how the blood flows around this image and things like that. So usually it shows you both perfusion and then shows metabolites within the tissue, the disruption or the mix of the metabolites helps us to also further characterize the type of tissue we are dealing with. This is also another multi-parametric imaging, not just showing you just the tumor characteristics, but also can also show you if there's recurrence. Like in this patient that had, a surgical glioblastoma being treated, and subsequently, of course, the diagnosis was made using spectroscopy and perfusion imaging, but subsequently, the last image, 6 months follow-up, confirms that there's increased enhancement around the tumor, so that increased activity. These are the kind of things you will want to do with using novel techniques or advanced techniques to further characterize tumors and be able to see how they respond to treatment. Okay, so these are also more what you call subtraction techniques. Subtraction techniques are techniques that helps us to not just characterize tumors, to be able to also define the margins of tumors, how these margins are, how irregular they are. So if you do what you call a subtraction technique, you're able to segment the tumor and further better characterize the margins of the tumor. These are also other unique novel techniques that are used to characterize tumors. Here you have what you call an effective T2 mapping, where you just look at just T1 and T2. You also want to look at the proton density of the tumor, how much how much the constituent, the density of the tumor can tell you also the activity that's going on within the tumor. There are also other techniques like what you call double inversion recovery, which is not, apart from the conventional T1 or T2 flare imaging, you can suppress water, you can suppress, just suppress CSF and also suppress the white matter tracts to further demonstrate the nature or the severity or the relationship or further characterize a tumor more significantly, as you can see in this case. If you see closely here, the T2 weighted images demonstrate the tumor with perilesional, white matter changes. In the flare images, which cause the tumor is better characterized.
It's just a few minutes for Prof to log in. I think his network just went off. I hope you just connect it. Meanwhile, you can type your questions in the chat box. The presentation should round up in 4 minutes.
You have to read what you said.
Yeah, sorry. Okay, sorry, Prof's network. Just if the network went off, I'm trying to contact him privately. Meanwhile, you can type your questions in the chat box. It's in the chat box. Already coming on, so we won't waste so much time. Once he logs on, just to see the questions and answers. Okay, so Jean Refer from Kenya. The question says, how can MRI be used in the therapy treatments in Uganda countries? With all the advanced techniques, can centers with 0.3 Tesla MRI utilize and achieve the same outcomes? What are the limits? Essentially, it's the same question I have for you. So I hope you don't come on very soon to answer the questions. The presentation will round up in 2 minutes. It's supposed to round up in 2 minutes, not for. So let me try to reach you privately. Please try to call me. He's just hanging for me. Yes, yes, sir. So you coming over. Okay, good. Thank you, sir. And thank God you're back on. So you have 3 minutes.
How what?
The question.
3 minutes to round up the presentation.
Okay, please allow me to share my screen.
Sure, you can.
Allow.
I think you can. You should be able to share your screen now. You should be able to do that now.
Okay. Make me a host. Sorry about the interruption.
Yes, you are. You are a host. Yes, you are a host, alright.
Okay. It's not allowing me to share my screen. Oh,
Okay, we are sharing it from here. I don't know if you can see. I don't know if
I see. Yeah. Go. You want to allow me to share? I can't. Okay.
you see us now.
Yeah, I can see yours. Okay. So you okay? I can see your screen. Okay, go ahead. Keep moving. We have discussed all this. I guess.
It just it feels like I think this is where we start.
I mean, okay. Anyway, let's just and discuss with the questions later. I think I've discussed most of the cases. Just go, keep scrolling. Keep scrolling. These are cases of multiparametric MRI showing you perfusion MRI. with that imaging for tumor. Okay. Okay, and then tractography, showing you effects of tractography on tumors, and this one also showing you perfusion of MR perfusion. Keep going. Next one. Okay, you can stop here now. So apart from beautiful, so you can just see, you know. So with molecular therapeutics, you know, we can accurately and not just demonstrating the molecular tumors. We can include this into using computational methods. Next slide, just click, next click. Use computational methods to be able to predict the tumors respond to treatment, how the tumors will change over time. Okay? So radiomics and using AI techniques are other novel ways of bringing computational imaging to bear on more management. Okay, so these novel methods, as I've outlined, you know, they are able to help us not to just demonstrate the anatomical function, not to just demonstrate anatomy, but also function. And this that will give you what you call personalized patient treatment and improve or optimize therapeutic outcomes. Okay, overall, thank you very much.
Thank you very much for such an excellent and robust presentation. Thank you so much, sir. So we just got questions immediately. We have a few questions in the chat box. And I'll begin with my own questions is, can the old generation scanners actually use these techniques? Can it be used in the old generation scanners? Or what technology, what scanners can actually use these novel techniques now? And someone else also asked that question. Jean from Kenya asked the same question. So begin with that.
Thank you very much. Good question. So the conventional scanners, the conventional 1.4 do most of these techniques. They only require manipulations or what you call sequences, developing the sequences that can be able to, like, most of the scanners that you have can do spectroscopy. These are all software that are put on the machine. The magnets generate the signal. And what you need to do is only to be able to MRI, can do spectroscopy, can do DTI. The only difference is in the resolution and in the quality and in the time it may take. But an average MRI 1.5 systems can. Thank you.
Professor, please, can you switch off your video? I think that could help a bit. You can hear me with the audio. English should help. Okay, so there's another question. Question says, Alex Domain says, Professor, could you please shed more light into the CST protocol and will the slide the recordings will be shared after the presentation. So the question is, could you please shed more light into the CST protocol?
Okay, so yeah, so the chemical.
Yes, sir.
So just like I described, you shine a particular light on certain tissue that chemical components, and these chemical components are mostly protein components, like, and whatever protein component you suspect, you manipulate the sequence to be able to recognize that particular. Now, that will now resonate at a particular sequence, and it's just like when you throw something to maybe you throw a hot potato, or a hot maybe like a hot potato to somebody, and the person holds it for a while, and the person next to him, when he does that, is doing is transferring energy. So what the computer does is that the computer will measure that transfer. That transfer every call it chemical. So it is what the computer measures and color codes, and each chemical reacts in a different way. What is measured, and then you're able to use that to characterize your tumors more effectively. So that is what the CEST imaging does. And when you do that, you're able to say, oh, this particular tumor has this particular what do you call it, molecule, and that molecule is, you can say, not all tissues have the same molecules. So that difference is what you can use to further characterize or describe a particular tumor. Another question?
While you were talking, a thought came, when you were answering the question, a thought came to me. If we can use the chemical characteristics to know the tumor biology, the exact tumor itself, so can we say the CEST imaging can help in giving us IHC or giving us the exact tumor biology? Or can it be incorporated? Yeah, IHC, that's what.
Oh, exactly. That's what I was trying to say. Non-invasively now, you don't even need to do biopsy. You can, based on these advanced techniques, when you combine with PET MRI, combining PET MRI, combining multi-parametric techniques, combining stability with imaging, combining spectroscopy, you can up to 95 to 96% accuracy determine tumors, so that you can, in almost 95% accuracy, characterize tumors. Like I told you about the genetic component or the genetic classification of tumors using the isocitrate dehydrogenase pattern, whether you are talking about the mutant type or the wild type. With PET imaging, radio tracers and different radio tracers, you can help classify accurately. And now with intelligence and you can provide these results can be identified or characterized up to 95 to 96% accuracy in most cases.
Thank you, sir. So someone's hand is up, Bumba Ikima. Can you answer your question now? Bumba, unmute yourself and speak.
I just put my questions in the chat, but unfortunately they couldn't be read. So I just decided to raise my hand. Thank you so much, Prof Ogbole, for a good presentation. I just wanted to know the overall, like how many institutions in Nigeria they are doing MRI spectroscopy and MRI perfusion?
It will interest you to know that we use these advanced techniques. As we speak, I am not aware of, I think only one institution does spectroscopy. Other institutions, that most of these techniques are not done in most institutions. They are usually done mostly in tertiary hospitals where this more specific tumors. Generally, most MRI systems just use the basic sequences. In Nigeria now, I think maybe 1 or 2 institutions do advanced MRI techniques.
Okay, thank you so much. With that answer, like how can you solve this diagnostic dilemma of following patients post-treatment of brain tumors like glioma? Like, if this radiation necrosis, is this true tumor progression? Is this a pseudo response? Like, I just want to know, how are you solving this dilemma if most of the institutions, they don't do these advanced MR techniques like MR spectroscopy and MR perfusion?
Well, thank you very much. The truth is that we're not solving the problem, because what is that we still do what we call very empirical imaging of our patients. And I'm sure, because you know also, most of these techniques are not, since they're not easy to come by, they're very expensive.
Okay, Prof, thank you. My last. Okay, thank you. My last question. As you spoke about the IDH status and 1p19q deletion status. Like, I just want to know, out of curiosity, in Nigeria, did you start entertaining the prediction of these molecular subgroups in your radiological report? Because, like, the incorporation of molecular subgroups started way back in 2016, and yet in most African countries, we are still relying on histopathology report. But I came to realize that conventional MRI alone can also help us in predict some molecular subgroups of these tumors. Like, for instance, the famous T2 flare mismatch, which is having a high predictive value of about 99% of IDH mutant astrocytoma, meaning the grade 1. So have you started entertaining the prediction of molecular subgroups from conventional MRI imaging in your radiological report to help these fellow oncologists and neurosurgeons? Thank you.
Excellent question. These are the way to go, but currently we're not doing that. We do not have the classification. Like you mentioned, this will be the way to go. But currently in our departments, we're not using these techniques to sub-classify tumors with techniques. Is academic.
Okay. I hope you're done, Sako. That should be all for now. So we take the question from the chat box. Samuel Abidoye is asking, what are the neuroimaging techniques specifically for clinical application in AI? I repeat the question. Samuel Abidoye says, what are the neuroimaging techniques specifically for clinical application in AI?
Well, AI enhances everything. What happens is that what AI does for you is what you call it requires what you call data, and then it can help you aggregate that information and give you like a summary. So whether you are dealing with T1, T2, T1 contrast, or whatever modality or technique, the information you have and come up with something more definitive. And so a database. And if you have a database that has predefined, tumors, when the AI sees that particular tumor, it can give you suggestions of that. So all the techniques can be used with AI techniques. And the beautiful thing about AI is that with radiomics, it helps you to combine all these parameters together and give you some predictive analysis. So it combines AI, it combines all these techniques to give you some predictive analysis and characterization patterns. So you can be able to estimate based on previous data that has been collected.
Okay, I presume you're done. Okay, another question from Neka Umi. Can I go on?
Please go on.
Another question from Neka Umi. She says, just to clarify, does it mean that every MRI machine can perform spectroscopy and functional MRI, whether they have the software required for it or not? Okay.
Oh no, you need most machines. What I said is that most machines have the capacity to do basic spectroscopy. Most modern machines, most modern 1.5 technique, but usually you require what you call like a license. You require like the software, you require the sequence to be actually programmed into that machine, because what the machine is, have the magnet. So what or manipulate sequences to get a signal, and when that signal is gotten, is that interpretation. So you require the software to be able to do spectroscopy. You require a particular software to be able to do things like diffusion tensor imaging. So even the very low field MRI machines that are coming out with AI, with what you call compressed sensing, with methods, you can actually engineer these even low field MRI systems to do some of these advanced techniques using AI. What you call deep learning, using deep learning techniques. So the main thing is actually of a particular system, not just the magnets now. So we've gone beyond. So you can get similar with AI. You can get a similar information you can get from a 3 Tesla, from a 1.5, or from even from a 1 Tesla. We are using computational methods now and translate information from lower strength MRIs. So these are possible, but you require the software. If you're able to do that, then you can run them on your system.
Thank you, sir. 2 more questions and we are done. One from Sekiti. He says, why aren't we using the techniques in Nigeria as asked by Ibunda? And the second one says, okay, so go on, Prof.
Sorry, I didn't get the first question.
He said, why aren't we using the techniques in Nigeria as asked by Uganda?
And the second question?
Second question is there room for contrast usage in these techniques? What are they?
Let me answer the question.
The second or the first one?
The second question. Let me answer the second question first.
Okay, thank you. The second question says, is there room? Yeah.
Yes, there's room for contrast. Contrast can be used. But the beautiful thing about most of these new techniques is that you do not require contrast. The things like arterial spin labeling, you can do perfusion. You can do perfusion studies non-invasively by manipulating the signals you get from an MRI machine. Of course, when you give contrast enhancement also enables better characterization. But some of these techniques can be done non-invasively and without the use of contrast. These techniques, like I said, the problem on the machines, but most machines have the capability to, they can develop the software, develop the sequences, and adapt it to your machine. And once you can generate a signal and manipulate. And with current information we have with AI, you can generate, very quickly by manipulating even these old machines. But what you need to be able to develop those sequences. You need to be able to develop or have the computational sequences and run the sequences on your system. Thank you.
Okay, sir. So, Prof, I think we are done with all the questions. Just final words from you, sir, in summary.
No, just to say presentation. I must apologize for the challenges we have in our environment of my internet is not the best. I try to change, but I don't think it's doing justice. But I want to say that these new techniques are coming on board and that we should educate ourselves and make ourselves available to learn new things and begin even in our environment, and to be able to help our patients better by improving the skills that we have or using more efficiently the tools that we have. What I see with most of the MRI scanners in most of what you have an iPhone only used to take pictures. And most of the MRI scanners we have can do most of these advanced techniques, but we don't have the capacity to enable them to do those techniques, and we are losing out. First is to using the system for these new techniques to better provide.
Okay, thank you very much, Prof. We are very grateful for your presentation and for finding time to honor our invitation to be our presenter for the month. Thank you for the excellent and robust presentation and for all you learned, for answering our questions. We look forward to having you again in the future for an even more advanced topic and more interesting. Thank you, sir. And for our audience online, on site, we are grateful for any time to join our journal club this month. The topic and the presenter for next month is already up on the screen, so you can see. We have a seasoned medical physicist this time from the US, experienced in teaching and in practice. And our topic is adopting radioimmunotherapy against breast cancers. The date is 9th of May 2024, same time, and we meet here. So you register as usual as we did, and notifications will be sent promptly every week until we get to the day. Thank you so much once again. We're happy to have you all. Thank you.
Thank you very much.
Yes, thank you.
Thank you very much. We appreciate the presenter and we appreciate the organizer.
Thank you. Thank you so much. Thank you so much. It was worth your time. God bless you. God bless you.
It's just it.
It's when people
Thank you so much. It was a nice presentation. Thank you so much for being in attendance. Thank you so much.